Welcome to ECRI Institute's Evaluation Lab. My name is Jason Launders and I'm the Director of our Evaluation Program here at ECRI. Today we are continuing our series related to COVID-19 and we are returning to one of the topics we covered a few weeks ago, and that is N95 masks, because a lot has changed. There will be a lot of information presented to you in the next few minutes, and I would like to make clear that this recording, along with a lot of resources that go along with it that we will refer to, will be available free of charge to anyone visiting our resource center from tomorrow onwards. And at the end of this presentation, we also open up to Q&A, so that if you have any questions that you want answering today, please feel free to use the Q&A box in Zoom, and we will do our best while we have our experts here to answer your questions. Today, I am joined by four of my colleagues here at ECRI. I have Dr. Andrew Furman, who is the Executive Director of Clinical Excellence. He will be giving a clinical perspective. He has 18 years of emergency room experience as a physician. I also have Tim Brown, remotely. He is the Executive Director of Price Guide. We'll be looking at the supplies. I have Dr. Amanda Civic, who is a Principal Project Officer in my group. She has been well involved in infection control issues in the last few years and has a lot to share. And lastly, I have Chris Levanchi here in the lab with me, who will be looking at reusing N95 masks. But before we start, we get a lot of questions about how many people are using reprocessing techniques, etc. And we have three questions which we'd like to present to you right now using the Zoom poll feature. If we put those questions up. The first question is, what are you currently doing to decontaminate N95 masks? The second question is just as important, is how many cycles you're putting your N95s through, the maximum number of cycles. And lastly, the experience that your clinicians are reporting regarding reusing masks. So at the end of this presentation, we'll look at those results. I can see them clipping in. Wait for them to stabilize. And of course, we will present these results afterwards so that you can see what all your colleagues are doing at this time. So while those are coming in, Dr. Furman, please take over. Thank you.
Thanks, Jason. I just want to reiterate, as I did the first time we talked about masks and repurposing, this is less than ideal, but we're here to offer practical solutions to extending the supply of your PPE. And so that last and third question that Jason mentioned, we are really interested to know that icky factor. I mentioned how sweaty the inside of an N95 can get from my clinical experience. And we'd love to know if you can enter in the Q&A comments that you're hearing from your frontline staff regarding this repurposing aspect of the PPE. That'll be helpful for us to understand, and then we can share on our resource center site. So with that, I'm going to start with Tim. And Tim, can you tell me the update of the current supply situation?
Certainly. Thanks, Andy. So the situation itself does continue to remain fluid. By all reports, the stockpile has been depleted. And we recently conducted a survey of providers. And with respect to N95 masks, 55% of respondents indicated that they are currently out of stock with respect to the masks themselves. 26% have indicated that they're in short supply, and 19% have indicated that they currently do have masks in stock. From a manufacturer and supplier perspective, the traditional avenues to procure N95 masks are basically backlogged. All traditional manufacturers are reporting shortages, and if they have any supply, it is being rationed and allocated to existing customers only. So as a result, many providers have been exploring what we call non-traditional suppliers. And ECRI is working with ARM on collaborating and helping to vet these types of organizations for providers. ARM is focusing on domestic suppliers and looking at organizations like YoYoUSA.com, a yo-yo manufacturer now claiming to have KN95 masks. They are researching each of these domestic suppliers from multiple perspectives, verifying whether they have valid tax IDs, websites, reviewing their financials, and so forth. That list is available on arm.org. And then ECRI is in collaboration with them, where our focus is more on the international suppliers that many providers are being approached with. We are researching and vetting these international suppliers in collaboration with our Asia Pacific office, and we are identifying whether the companies are registered with the FDA or the NMPA, which is the Chinese equivalent of the FDA. So that list is available to ECRI members as well, as providers explore these non-traditional routes. Back to you, Andy.
Okay, thanks, Tim. And we're going to get to some more information about the imported masks later in the presentation. Amanda, I'm going to turn it over to you regarding what guidance is out there. When should healthcare workers be wearing N95s?
Sure, thanks, Andy. So current CDC and WHO guidance states that the SARS-CoV-2 virus is primarily transmitted through respiratory droplets from person to person. And so to protect healthcare providers, they should follow droplet isolation precautions, which requires the use of a face mask, isolation gown, eye protection, and gloves. But the CDC and WHO also report that airborne transmission of the SARS-CoV-2 virus is possible during aerosol generating procedures performed on COVID-19 patients. And so that would require healthcare personnel to use airborne isolation precautions to protect themselves, which requires the use of an N95 filtered phase piece respirator, or FFR, as well as eye protection, gloves, and an isolation gown.
Okay, and what are some of the recommendations out there for extending the supply of N95s?
Sure. So ECRI recently published a free report on our COVID-19 resource page. It's titled Strategies to Address Expected or Known N95 Respirator Shortages. And I'm just going to summarize those recommendations for you, but please do look at that resource because it goes into much more detail than I will. So there are a few things that healthcare facilities can do immediately, and that's to try to source industrial FFRs. So in addition to N95s, there's a whole class of single-use industrial FFRs. So R95, R99, R100s, and then the P95, P99, and P100s. Try to source those if you can. Also on our COVID-19 resource page, there is some support for facilities to try to find functionally equivalent industrial FFRs. So the second thing facilities can consider is to secure your inventory of FFRs. So it should ideally be in a secure room, but still accessible so that clinicians in an emergent situation can access the supply of FFRs when they need to. And then the third thing that facilities can do immediately is to minimize the need for healthcare personnel to use respiratory protection through the use of engineering and administrative controls. So CDC recommends several of them. Probably the three most important ones are performing aerosol generating procedures in an airborne infection isolation room on suspected or known COVID-19 patients, and then to cohort suspected or known COVID-19 patients in one patient care area, and then also cohort your healthcare personnel so that the same team of clinicians, nurses, physicians, as well as environmental services staff are taking care of COVID-19 patients. And then there are additional strategies. So if facilities start to change their routine care practices, they can go to extended use of filtering face piece respirators. And NIOSH defines that as wearing the same FFR between multiple patients and not taking off the FFR between patients. And so there's several recommendations there. Obviously, you need to adhere to the manufacturer's instructions for use, including conducting a seal check. And also you need to discard the FFR becomes soiled with body fluids or damaged or difficult to breathe through. And then when facilities have a low supply of FFRs, then CDC recommends to try to source non-NIOSH approved FFRs that are similar to NIOSH approved FFRs. I provided a slide of the table that is in CDC's recommendations. So you can see the different similar products that are offered in Mexico, Korea, Brazil, et cetera. So hopefully that will be of use to you. And finally, the last strategy that can be done if you have a low supply is to reuse FFRs. So if you reuse FFRs without decontaminating between uses, NIOSH recommends that ideally you would provide 5 FFRs to each healthcare personnel that's expected to perform aerosol generating procedures on expected or known COVID-19 patients. And then to follow the manufacturer's recommended number of donnings, or if they don't have a recommendation, because these are single-use products, to don 5 times. And also that you should store the respirators in a clean paper bag, not touching one another, with the respirator straps labeled as well as the bag labeled with who the healthcare personnel's FFR it is. And you should store the respirator for at least 3 days between uses, which is the maximum amount of time that is believed that the SARS-CoV-2 virus can survive on surfaces. And finally, if facilities don't have any more respirators, then you have to implement really crisis strategies, which include designated healthcare personnel that have recovered from COVID-19 to preferentially provide care for suspected or known COVID-19 patients, as well as excluding personnel that are at really high risk for severe complications from COVID-19 from providing patient care for these suspected or known patients. And finally, as a last resort, if your facility runs out of FFRs as well as medical grade face masks, CDC says that you should use homemade masks as a last resort, and that they should be worn with a full face shield that covers the entirety of the user's face down to at least the chin, and then to the sides of the face to the ear. Back to you, Andy.
Thanks, Amanda. Yeah, that's scary thoughts. Let's hope our viewers have supplies. And I guess, Chris, we were here a couple of weeks ago and we were talking about UV as the best decontamination option. What's changed?
Yeah, so you may recall ECRI had done a literature search to see what studies had been done to figure out the best ways to decontaminate N95 masks. And if you look at the data, it turned out that UV was one of the more promising ways to do it because there was a lot of information about how well it works and showing that it actually is pretty effective. Since then, though, a couple of weeks ago, a company called Battelle got an emergency use authorization, or an EAU, from FDA that allows them now to use a system that they've come up with. It's an industrial scale mobile system that they can bring to cities where there's a high density of patients and use it to decontaminate N95s off-site. So they'd be shipped to the device, to the system, and then shipped back to hospitals. Subsequent to that, last week, Steris got an EAU to use their VPRO series sterilizers, which are also hydrogen peroxide sterilizers, to decontaminate masks. And then a couple days later, ASP and their STERAD series of VHP sterilizers has also gotten an EAU. So things have changed quite a bit. There are now many more options than there were, at least the way we were looking at it, based solely on the literature. Now there are other options that have been examined and may be available.
And tell me a little bit more about this emergency use authorization and what these sterilization companies had to go through different than UV.
Okay, sure. So an emergency use authorization, or EAU, is an action that authorizes FDA to kind of shortcut their normal process of allowing medical devices to get put on the market. So this is, of course, only invoked during situations where there's a national medical emergency like we're dealing with now. And it allows FDA considerable flexibility in getting products to the market that can be very helpful in these situations. And it also allows them to extend, or manufacturers to extend the indications that they currently have for existing medical devices. So it can be very powerful. And FDA has used the EAU several times already for a number of different things, including, for example, diagnostic tests for COVID-19.
Yeah, we have a position paper up regarding diagnostics tests in the EUA and what that looks like on the Research Center right now regarding antibody testing.
So for the vaporized hydrogen peroxide sterilizers, these are technologies that have been around for a little while. And what FDA requires is that there's a definition in the EAU of the cycle that's required. There has to be also some kind of a metric that can be used to verify that the cycle worked properly, like a chemical indicator. And the manufacturers also have to come up with validation data showing that they can in fact kill representative pathogens like non-envelope viruses and things like that. And they're also required to look at the compatibility of N95 masks as they're exposed to this sterilant. And then lastly, they have to come up with a chain of custody process, or a process that ensures that the mask that you're wearing today will be the same one that you'll be reusing going through time.
That's good to know. Well, are all masks the same? I mean, can any mask be decontaminated under this process?
Well, that's a very good question. There are numerous manufacturers of N95s in this country, and you would think they'd be all different designs and styles and so forth, and they do vary quite a bit. But fortunately, for the most part, they're all made, the mask material itself is all basically a polypropylene fiber material that allows this filtration to work the way it does. So that makes it a little bit easier because we kind of know what we're working with. One concern that was raised with vaporized hydrogen peroxide, or VHP, is that if there's any cellulosic material in the mask, things like paper or cotton, rayon, those materials will react with hydrogen peroxide and actually consume it. So you may not get the effective sterilization that you're intending to do.
Can I tell the difference?
Not by looking at the mask, no. Unfortunately, it's not that simple. But the good thing is we've been doing a little bit of research on this, and it turns out that very few manufacturers actually use cellulosic materials. And we've talked with manufacturers across the country and collected a list of products that may contain cellulose, and that will be posted on our COVID-19 Resource Center.
Okay, great. Can you tell me some of the differences between UV and hydrogen peroxide?
Sure. So with UV, the decontamination process is fairly straightforward. With the mask, you have to make sure that all surfaces are going to get exposed and get the appropriate dose. So that may mean, it means putting the mask in such an array where they can get the exposure that's required. It may also mean you have to do 2 exposures if you only have one light source. If you have 2, you could put them on either side and not have to flip it around. Overall, it's a pretty straightforward process once you figure out how to get the dose you need. And there's not much that has to be done with the mask during the reprocessing. With vaporized hydrogen peroxide, it's a little more complicated, particularly with the systems like the STERIS and the ASP processes. These are low temperature sterilizers that are already in hospitals, and similar to other processes that you would use to sterilize medical devices in these machines, you have to put the mask into a pouch similar to this, and then each one can then be put into a rack within the sterilizer and the cycle can be run. There are some differences between the performance of these, or the cycle time that's required. Generally they run about half an hour to up to an hour to do the actual cycle. With ASP, it's necessary to do an aeration step afterwards, which lasts about an hour. So that has to be taken into consideration. One of the things that is a concern with vaporized hydrogen peroxide is the concentration of this hydrogen peroxide is not what you typically are familiar with from your drugstore hydrogen peroxide, 2 to 5%. This is more like 30 to 59% hydrogen peroxide. It's very nasty stuff. If you get it on your skin, it's going to really cause some nasty burns. So one of the considerations is, are you able to successfully get that hydrogen peroxide out of the mask to a point where it's safe to wear? And each of the companies has had to look at that, and that's why I mentioned the ASP has found that they have to do a 1-hour aeration after the cycle has run to make sure all of that hydrogen peroxide is at a safe level. The other thing is the ASP cycle or process can be used only 2 times for a particular mask. So you can use it twice, or you can have it decontaminated twice. With STERIS, the VPRO systems, you're able to do the reprocessing up to 10 times. With the Battelle system, up to 20. So there's quite a bit of difference in terms of the capacity to reprocess these devices.
Okay. And you mentioned 3 companies, in the beginning, and how are they different, and how might a health system kind of start using what they have?
Well, that is a tricky question to answer. Each hospital, each healthcare facility is going to have to look at their situation. If they happen to be in a densely populated area, a city, where one of these Battelle systems may have been moved to provide the off-site decontamination, that's great. That may be the best solution for you, because a lot of the management and handling of the decontamination is all being done for you, which makes things much simpler. They also encode in a barcode the information about where it came from, who was wearing it, and that type of information. So the chain of custody could be quite a bit simplified over having to do all that yourself. If you don't have that option, though, and many places won't, because we understand that Battelle only has a couple of these systems at the moment, you'll have to look at what you have in-house. If you have the STERIS system, that's probably going to be your best bet, the STERIS VPRO. If you have the ASP STERAD system, that's probably going to be the one of choice, just because of convenience of having it already in-house. You're not likely to be able to order one of these machines and get it delivered quickly, given the current situation. So you have to work with what you have.
But there are a lot of them out there.
Our understanding is that there are, I believe, 60, I think I saw somewhere around 7,000 of the ASP units out there, and some 2,000 facilities have the STERIS systems.
Okay.
So they're quite prevalent.
So it becomes another practical option. Just now, kind of shifting back a little bit to Tim mentioned imported masks.
Yes.
What can you say about those?
Well, I mean, that is an option that has opened up. FDA had an EAU for importers of these masks that are made outside of the U.S. The challenge there, though, is that it's difficult to know whether you're getting something that's legitimate or a fraudulently made product or marketed product. And this has happened. We're aware of healthcare facilities that have shipped a lot of these over and then realized afterwards that what they were getting was in fact not what it was represented to be. So there are a lot of challenges with using imported products, but I don't want to rule it out. I don't want to say it's not viable. but you do need to do a fair amount of work to verify that they are, in fact, legitimate products. And ECRI is going to be posting a number of sites that will help you vet a vendor or a supplier and distributor, and you may be able to use that to try and identify the best products. I will say, though, we are aware of at least one situation where a product was NIOSH certified. It had the appropriate NIOSH code on it, indicating that it had been tested. You could look it up and find it was there. But when we did a little bit more looking, we realized that that was in fact a counterfeit product that someone had made to replicate exactly, what is a legitimate product. So there are a number of things that we can recommend. First off, if you're going to do this yourself, what you're going to need to do is see if the mask manufacturer is registered with FDA, because that is a starting point. You can also, not all manufacturers will be, but ones that are legitimate more likely would be registered. You'll also want to know if the mask is certified with a standard that's aligned with NIOSH's N95 certification. If it is, that's promising. If the mask has a NIOSH certification, it makes it fairly easy to confirm that it's legitimate, because the mask will have on it a NIOSH number, a TC number, that you can then look up, and it will be associated with a particular manufacturer. So you'll know whether or not the mask you got from the manufacturer was in fact one of theirs. And then the other thing I'll mention is there's some very basic things you can do when you look at the mask and the construction of the mask. Does it look like it's made well? Does it have any loose pieces like the metal band that's used for the nose piece? Is the foam securely attached and the straps securely attached? You can also look at things like the straps themselves. If you're seeing ear loops rather than headband straps, that should raise some concerns, because in general, NIOSH has raised questions about whether the ear loops provide a good enough seal against the face. If there's a single headband, that's also kind of a question, because typically you would expect to see two to really position and hold the mask in the proper place.
Okay. Jason.
Thank you very much. Thank you, Chris, Amanda, and Tim, for sharing all your experiences. We now have the key recommendations based on all the presentations that you've just had. I'm not going to run through them, but that's the sort of order or sequence that we're recommending that you select your N95s and reuse them. And as you see, number 6 and 7 number 7 is reusing without decontamination. That's when you have it sitting around for a few days between uses. And then we move into the sort of yellow and red zones, which we didn't really address too much. Amanda did talk about using homemade masks. We want to make that clear that that's as a mask and not a respirator, which is on number 9. We are not recommending the use of non-traditional N95s or homemade ones that we cannot tell where they come from. Next, I would like to show the results from the poll we had earlier today, or just at the beginning of this. I hope you can see those. And we will be publishing those. I cannot see them. We will be publishing those so that we have reference to those. So now we'll move into the question and answer section of this webcast. And if you use the Q&A tool, we'll do our best to answer your questions. Thank you very much. Okay. Nursing administration is getting questions and concerns over the reprocessing of N95s. Most complaints are from the physicians, as I'm hearing it. So that's more a comment rather than a question. Do you know of scientific basis for reprocessed masks to be deployed back to the original user of that mask? Are there proven reasons to do so, other than making the end user feeling doing so is a safer approach? Chris.
Let me see if I can answer that. So In terms of, I can particularly comment on the vaporized hydrogen peroxide. What FDA has done in getting clearance for these products, or required in getting the EUA, is that the manufacturer has to show, of the sterilizing system, they have to show that they can effectively decontaminate the mask and also still preserve its performance. So that's something I didn't get into in a lot of detail, but when they look at the compatibility of the mask with the sterilant that's being used, they're also doing testing with the manufacturers of some of these N95s to verify that they still perform as they should when they're new. So I feel like that there's very good scientific evidence that this can work properly.
The next question is, when you're reprocessing masks, were you required to use the specific brand of pill pouch, or is any brand the same as any other?
I would defer to the manufacturer of the sterilizer to define which pouches you can use. You probably could use an off-label one or an off-market one, but just for your own assurance, you may want to use the one that the manufacturer supplies.
Okay. Next question, again for you, Chris. STERAD's EUA states only placing one mask per pouch, but our internal testing with our STERADs through a full cycle and chemical strips between 4 and 5 masks in the same pouch. Shows decontamination was achieved. Could ECRI conduct similar tests to test this?
Now, ECRI is not in a position today to do that kind of testing to validate whether the approach you're describing would be effective. I would caution anyone taking that approach to talk with the manufacturer about it, because in getting their EUA, they went through a lot of testing and would be able to comment on what problems you may run into by modifying the protocol.
Okay, the next question is, both STERIS and STERAD recommend using a Sharpie to write the owner's name on the mask for decontamination. The mask manufacturers don't recommend writing on the mask, only the strap. Is that our recommendation too?
Our recommendation has been, if you can, you should use the strap. I mean, it's certainly less likely to be an issue, although there's not a lot of room to write on. That may be the problem.
We've got a few questions asking whether the material that we displayed during this presentation will be available, and everything that we've displayed and referred to will be available after this to all users, including the charts with explaining the differences. Next question. What are your thoughts on Selfmade UV machine that is not FDA approved to do this process?
Well, first of all, none of the UV room decontaminators like the system over here or the tabletop or countertop type machines get FDA approval. Those are not considered medical devices, and I think the concern there is you want to make sure that where you're buying one of these, you're getting from a reputable manufacturer, and that they can provide information, for example, about the dose required or available after a certain period of exposure. So all that information should be readily available from a company that's done the appropriate diligence before they put their product on the market.
Thank you. A question about ETO is have we done any review of those processes?
We talked about ethylene oxide in our last webinar about this, and our concern there is that ethylene oxide has really fallen out of popularity in hospitals just because of the environmental and occupational hazards associated with it. It's possible you could find a commercial ethylene oxide sterilizer, but even they are running into issues today with EPA. So we really decided not to pursue ethylene oxide as a viable way of managing decontamination.
Another question about UV is, are there any FDA-approved recommendations for the UV use for decontamination?
I'm not aware of any.
Okay. Again, UV is not an FDA-approved.
Correct. UV is not regulated by FDA, at least not the type of machines that I was pointing to before.
Is there an option in the works to use hydrogen peroxide to reprocess HEPA breathing circuit filters?
I have heard people discuss that possibility. It's possible they could do it. I don't know if anyone's done any real studies to verify that.
Okay. There's a question, it's asking whether we support the CDC guidelines in that N95s should not be widely used for PUIs or positive COVID-19 patients unless aerosol generating procedures are being performed. Rather, a surgical mask should be used. Amanda, can you address that?
Sure. So based on the current recommendations for CDC and WHO, they report that airborne transmission of the SARS-CoV-2 virus is possible during aerosol generating procedures on COVID-19 patients. So that requires the use of a respirator, and then the other required PPE, so gloves, isolation gown, and eye protection. Otherwise, they say during routine patient care that a face mask is appropriate.
Thank you.
PPE.
Thank you. Is sterilizing necessary or is disinfection sufficient? I don't believe that N95s are sterile when they are first used.
That's correct. They're not typically a sterile product. The thing I'd like to emphasize is none of the processes we've described as a decontaminating method, a viable decontaminating method, can assure sterility. It's just impossible because you don't know what kind of viral load you're starting with and what type of soiling there may be on the mask that would prevent complete annihilation of all viable microbes. So I think it's important to understand why this is being called decontamination as opposed to sterilization.
How many times can an N95 be used if a face shield is always used with it at the same time?
So are we talking about with decontamination in between, or are we talking about just reusing? I'm not quite sure.
Just decontaminating in between.
Okay, well, the number of uses is defined by testing that shows how much degradation of the performance of the mask is attributed to each reprocessing cycle. So unfortunately, putting a face shield over it will help protect it, but you're still, each time you're running it through one of these decontamination steps, you are doing some level of degradation to it from the method you're using. And when we talk about an upper limit for the number that can be reused, that's what it's referring to, not how much stuff is on the surface of the mask.
Thank you. This is more a suggestion than a question. It says, we have implemented using a patient ID band to write the staff name on and then wrap it around the elastic bands during sterilization.
It's an interesting idea. In general, I know that was discouraged. Using any kind of label or extra component was discouraged because you don't know whether or not that product can go through the decontamination process that you're going to expose it to. So for example, the VHP sterilizers, is that band designed to be sterilized? Is it going to be affected by the sterilant? So if it works, great, but just be aware it could introduce its own problems.
A question about UV, and this facility is using UV in their fume hoods, and they found literature saying 300 millijoules per centimeter squared, which is what we've said on our charts. Do we have any recommendations to say when do they know that they've got to that level?
This is something that in our previous lab video we discussed, that you really need to talk with the manufacturer of the system that you're using and find out what kind of dose it can provide at a known distance and what the time is required to get to that dose. Mm-hmm. It's something that unfortunately it's difficult to just give you a guidance on how to have that information without doing some testing, especially if you don't have a way of measuring the actual irradiance from the source.
Thank you. Is the FDA's EUA for decontamination of N95 specific to the device manufacturer or a blanket authorization for sterilizers, disinfectant devices, and air purifiers?
Okay, that is a very good question. So the EUA, just like a 510K, if you're familiar with that concept, is very specific to the manufacturer. That's why Steris and ASP and Battelle each had to get their own EUA before they could be allowed to do the marketing of their product for that purpose.
Mm-hmm. The Nebraska study, referring to UV, used a certain N95. Is it acceptable for all types of N95?
To the best of our knowledge, and this comes back to what Andy was asking, it depends on what's in the mask, but for the most part, their construction is apparently quite similar. So we believe, based on the numerous studies that have been done with UV, that the overall performance of the decontamination will be similar, and presumably the degradation rate with multiple reuses will be similar.
We have another question asking about specific types of masks. Are they viable alternatives? Rather than going through the list, I'll say that we do have a nice chart listing all the types of masks which are alternatives, whether they come from Europe or China. So that will be available after this. The next question is, can you clarify the need for N95s for a potential COVID-19 patient and cleaning of the room off by the staff? Are you recommending that an N95 and a full PPE be used to clean?
I think that would be a question for Amanda.
Amanda?
Sure, I can take that. So, yes. So if you had a room where you had an aerosol generating procedure performed on a COVID-19 patient, then the personnel who are going to perform the cleaning and disinfection of the environment that the patient was in should wear a filtering face piece respirator, as well as an isolation gown, eye protection, and gloves. And for cleaning and disinfection, follow the recommended instructions for use for performing cleaning and disinfection. And particularly for SARS-CoV-2 disinfectants, ECRI provided a list of these disinfectants based on the EPA's List N that is freely available for you to reference, so that you can see the disinfectant concentrations and contact times required to kill this virus in those areas.
Okay, well, thank you very much for all those questions. Any that we didn't answer, should be answered by looking at all the resources and materials that we will be posting or have already posted. I'd like to just run through some of the polling results. We're showing that about 50% of facilities are currently decontaminating N95s with about equal use, thereabouts, between UV and hydrogen peroxide. The maximum number of cycles, some people are going to greater than 10, but 1 or 2 seems to be fairly popular as well. And the feedback from the clinicians is that we're hearing that 39% are saying they feel that they are safe, 12% are commenting on odors, and about 3% are experiencing side effects when they're decontaminating masks. So thank you for that. With that, we thank you for joining us today, and we thank all clinical staff for going into the front line and treating these patients in such terrifying circumstances. And we look forward to joining you again with another of these webcasts. Thank you very much.